It's a pleasure to be with you. The title of this talk is Raise the Rate, Improving Provider and Patient COVID-19 Vaccine Confidence at the Medical Encounter. There are no disclosures for this presentation. Objectives include review COVID vaccination rates, discuss common concerns and questions about COVID disease and vaccines, review morbidity and mortality of COVID-19, review complications for survivors of COVID infection, review the attributes and impact of the Delta and Omicron variants, understand current evidence for COVID vaccine efficacy, explain base rate fallacy, review booster and third dose recommendations, review the Vaccine Safety Datalink program as part of the U.S. vaccine safety system, review COVID vaccine safety, discuss approaches to vaccine conversations during the medical encounter. This charts the U.S. and North Dakota COVID vaccination rates since January 12th of 2021 to November of 2021. North Dakota was tracking parallel with U.S. rates until April to May of 2021, when North Dakota started to diverge from U.S. rates, with vaccination rates tending to plateau. The inserted table shows the COVID vaccination rates as of January 13, 2022. The U.S. single-dose vaccination rate for individuals 5 years and older was 79.4%, with 66.8% having completed a primary series. North Dakota had a single-dose vaccination rate of 54.8%, with 51.7% having completed a primary series. The U.S. booster dose vaccination rate for those 18 years old and older was 40.6%. The North Dakota booster dose rate for those 18 years and older was 44.5%. This graph reviews COVID trends in vaccination status and intent between April 22, 2021 and January 29, 2022. As of January 29th, approximately 70% of North Dakotans are either vaccinated or definitely plan to get vaccinated, with approximately 10% of the population who say they probably will get vaccinated or are unsure about COVID vaccinations, leaving 20% of the population who say they probably or definitely will not get vaccinated. There has been a decrease in measured vaccine resistance and hesitancy from November 2021. Common concerns and comments regarding resistance to receive COVID vaccines include, are COVID vaccines really necessary? Some individuals feel the whole COVID-19 issue is being inappropriately exaggerated, feeling that it should be considered similar to seasonal influenza. Other individuals aren't sure they personally need the vaccine since they are young, healthy, or already had COVID-19. Are COVID vaccines effective? Are they safe? Do they cause significant short and long-term adverse reactions? Safety concerns include the speed at which these vaccines were developed. Were safety steps short-circuited during the development of these vaccines? Other safety concerns include, can mRNA vaccines change an individual's cellular DNA? Do COVID vaccines cause infertility? Do they cause excessive risks for myocarditis, thrombotic thrombocytopenia syndrome, Guillain-Barré syndrome? Do these vaccines include microchips or magnetic particles, etc.? They don't. These questions, concerns, and comments are important to address with our patients and the general public. Let's briefly consider the question, are COVID vaccines really necessary? All-cause mortality in 2020 and early 2021 was anywhere from 5,000 extra deaths to almost 40,000 more deaths per week than prior trends would predict. All-cause mortality is up during the pandemic, likely reflecting the significant impact of COVID. Excess mortality in 2020 and 2021 vastly exceeds one of our worst flu seasons in the last decade in 2017 to 18. As demonstrated, the weekly number of deaths dramatically declined with the initiation of COVID vaccination programs. COVID has caused more deaths in the United States than all the fatalities of World War I, World War II, Korea, Vietnam, and 9/11 combined. Most of those deaths could have been prevented through COVID vaccinations. Let's next consider the statement of this young man. To appropriately understand his reasoning, we need to understand the difference between the COVID fatality ratio, also known as the infection fatality ratio, and the COVID case fatality ratio. Some people inappropriately use the terms rates and ratios interchangeably. Both rates and ratios are a comparison of two numbers. A rate is simply a specific type of ratio. The difference is that a rate is a comparison of two numbers with different units, whereas a ratio compares two numbers with the same units. That's why many epidemiologists would use the terms infection and case fatality ratios, since they use the same units in both the numerator and the denominator. The infection fatality ratio is the number of deaths divided by the number of infections expressed as a percent. This ratio requires identification of symptomatic and asymptomatic individuals who are infected with an agent like COVID-19. Many asymptomatic or mildly symptomatic individuals may not seek care, therefore may not be identified without using tools like random population serologic sampling for evidence of a prior infection. The case fatality ratio is the number of deaths divided by the number of cases expressed as a percent. Cases must meet case definitions for a disease and most often require laboratory confirmation. Cases are usually individuals who have clinical symptoms ranging from mild to severe and seek clinical evaluation and care. Case fatality ratios may be developed for groups of individuals stratified by symptoms and severity, like those individuals hospitalized versus those who were managed as an outpatient, etc. It's important to understand the difference in the infection and case fatality ratios when discussing the impact of COVID-19 in a population. So when people say that 99.9% plus of people with COVID survive, they are talking about the infection fatality ratio, not the case fatality ratio. Cases, as mentioned before, are individuals who often have symptoms and present for evaluation and testing. The infection fatality ratio for COVID averages 0.1%, with a range from 0.01 to 0.67%, and is less than the COVID case fatality ratio that is generally calculated at 1.6% in the United States, meaning that 1.6% of individuals who seek care and are infected with COVID will die. This case fatality ratio for COVID is high. COVID vaccinations can significantly decrease the risk of severe disease and death from COVID disease. So if I get COVID and am in that 98 to 99% of people who survive, what does survival look like? This study published in 2021 demonstrated that death following a COVID-19 hospitalization within 10 months of discharge was on average 63 to 73% higher than deaths following hospitalization for similar patients discharged after hospitalization with influenza, considering variables of age, sex, geography, ethnicity, various comorbid conditions, obesity, smoking, and patients from institutions for mental disease, IMD. The HR is the hazard ratio of death of patients hospitalized with COVID versus influenza during the 2017-18 season, represented by 1, the dashed line, as a control. So even if a person survives hospitalization with COVID, death after hospitalization is 63 to 73% greater than death after hospitalization for influenza during the 2017-18 season. COVID vaccination decreases severe disease, death, and infection rates. Let's consider a local survivor story to personalize post-survivor complications from COVID infection. Brady Monroe from Page, North Dakota, was a healthy 23-year-old and engaged to be married. He played football for Valley City State College. He contracted COVID when his family went on a vacation to Florida. He became severely ill, requiring ICU care, a ventilator for 3 months, and tracheostomy. He was hospitalized for 100 days. He developed septic shock, blood clots, kidney failure, and adult respiratory distress syndrome. He lost 80 pounds during his hospital stay and is currently facing prolonged rehabilitation. This is what 98 to 99% survival can look like. COVID vaccination decreases severe disease like that experienced by Brady. Let's discuss long COVID and survivors for a few minutes. This article in Lancet from August 28, 2021, reviews the one-year outcome of hospital survivors from COVID-19. Matched COVID-19 survivors at 12 months had more chronic problems with mobility, pain or discomfort, and anxiety or depression versus controls. Most common long COVID symptoms and problems described in this article included persistent abnormalities on CT scan of the chest, fatigue and weakness, and ongoing shortness of breath. 88% of patients who were employed before COVID-19 had returned to their original work at 12 months. Women had more fatigue or muscle weakness, anxiety, depression, and gas exchange or diffusion abnormalities than men. This study from JAMA looked at prolonged symptoms per age group at 6 months post-COVID. 6.2% of these individuals had an asymptomatic infection. 84.7% were outpatients with mild disease, and 9% had moderate or severe disease requiring hospitalization. The most common prolonged symptoms included fatigue, anosmia, ageusia, and dyspnea. Prolonged symptoms were reported in 26.6% of those in the 18 to 39-year-old group, 30.1% in the 40 to 64-year-olds, and 43% in those over 65 at 6 months. 7.9% of these patients reported negative impacts on at least one activity of daily living, the most common being household chores. Overall, 49 of 150 outpatients, 32.7%, 5 of 16 hospitalized patients, 31.3%, and one of 21 healthy participants, 4.8% in the control group, reported at least one persistent symptom. So prolonged long COVID symptoms occur more frequently in older individuals, but can even impact individuals with asymptomatic or mild disease post-infection. Long COVID is a concern for survivors. United Kingdom data suggests that approximately 5% of COVID-infected individuals develop long COVID. COVID vaccinations may decrease the incidence of long COVID. The United Kingdom Biobank study is an ongoing prospective cohort study utilizing surveys and high-tech brain imaging on a cohort of 100,000 British study subjects since 2014, assessing a number of different risk factors for various diseases. The researchers recognized they had a unique opportunity to study the effects COVID might have on the brain, comparing 394 COVID patients with 388 matched controls. They found 5 areas of the brain that had statistically significant areas of shrinkage after COVID infection. These areas of the brain are those responsible for taste, smell, emotion, and memory processing and storage. These anatomic areas of abnormality correspond strikingly well with the functional areas of impairment noted in this JAMA study from October 2021 on neuropsychiatric testing after COVID recovery, demonstrating a pattern of brain executive function loss, of frontal lobe syndrome, and memory processing issues. These abnormalities were more frequently observed in hospitalized versus outpatients with COVID. So survivors of COVID infection may experience brain complications more frequently observed in those hospitalized with COVID versus outpatients. COVID vaccination may decrease the severe disease requiring hospitalization and thus reduce brain complications. This is a graph from a study in the United Kingdom demonstrating that vaccinated people who get COVID are 40 to 50% less likely to suffer long COVID compared with unvaccinated individuals, which is similar to other studies. Several studies have demonstrated that COVID-19 infection is associated with new onset diabetes mellitus. In children, this can be as high as 1.3 to 2.7-fold increased risk of diabetes reported in the MMWR in January 2022, and a 57% increase in another study reported in JAMA. There was a 40 to 70% increase of diabetes in adults up to 1 year after infection. The VA study demonstrated a 3-fold increased risk if hospitalized. Let's now consider how the Delta variant changed the pandemic. This World Health Organization statement describing the Delta variant was so true. The Delta variant was more efficient at transmission due to genetic changes that allowed it to produce larger numbers of infectious particles. It therefore was more fit for survival in humans than previous variants and faster, since its characteristics enhanced the speed of transmission. The viral load of Delta infections was approximately 1,000 times higher than that of earlier coronavirus strains that caused the initial pandemic wave of 2020. That increased viral load was likely due to a more efficient and rapid viral replication rate, resulting in enhanced viral transmission. Putting this in perspective, Delta was estimated to be 2 to 3 times more contagious than the original strain of COVID-19 and was at least as contagious as chickenpox. Hospitalizations and deaths, primarily due to the prevalence of Delta, rose in the under 65-year-old age group and yet remained flat and low in those over 65. As previously mentioned, this plateau of Delta hospitalizations in those over 65 may have been in part due to the higher vaccination rates of the elderly. Some data suggests that Delta was up to 2 times more likely to result in hospitalization. Let's briefly discuss current information on the Omicron variant. It appears that the Omicron variant is much more transmissible versus Delta. This is likely due to the marked increased replication of the Omicron virus versus Delta, with approximately 70-fold increased viral particles in various respiratory secretions. This increased transmissibility is causing marked spikes in cases around the world and is much more likely to cause infections in households than Delta. One study suggests household transmission with Omicron is increased by 3.2-fold over that with Delta. This graph shows the 7-day testing positivity rates in North Dakota from April 2020 to January 12, 2022. The testing positivity from July 2021 to December 2021 was mainly due to the Delta variant. The marked rise in late December and early January is likely due to the Omicron variant that rapidly became the dominant variant across the state and nation. This graph shows the increased incidence of Omicron infection in individuals under 55 years old, and particularly in those 18 years old and younger. Viral mutations of the Omicron variant result in a significant loss of viral neutralization after a previous COVID infection or even after vaccination, therefore resulting in increased reinfection risks. So prior infection with COVID does not seem to provide neutralizing antibody protection for Omicron versus other variants. These graphs, E, F, and G, demonstrate laboratory convalescent neutralizing antibody activity after a previous COVID infection with other variants against Omicron. As demonstrated, there's almost no neutralizing activity of that post-natural infection convalescent antibody against Omicron. Graph H demonstrates the significant neutralizing antibody activity against Omicron of super immune individuals like those receiving booster doses of COVID vaccine. So booster doses of COVID vaccines dramatically increase neutralizing antibody and protection against symptomatic infections. Boosters likely provide 76% protection against infection and 85 to 90% protection against severe disease. A 2-dose series of Pfizer or Mrna mRNA vaccines provide about 70% protection against hospitalization, but only 10 to 33% protection against infection at 20 weeks post-second dose, as reflected in studies from South Africa and the United Kingdom. This underlines the importance of booster doses. A new subvariant of Omicron has been identified and is being called Stealth Omicron. Its moniker comes from the fact that certain genetic lab tests can't identify the genetic structural differences of this BA2 stealth variant. Currently, it seems this variant presents with similar symptoms to the original Omicron variant. A report from the United Kingdom suggests that current vaccines provide similar protection against the stealth as with the original Omicron variant. This variant accounts for about 50% of new COVID-19 cases in Denmark and has become the dominant strain in India. It has been identified in the US. This graph demonstrates that previous infection with the original Omicron variant BA1 provides protection against infection with the BA2 stealth Omicron variant. A new coronavirus variant, Deltacron, has emerged in Cyprus, which has a similar genetic background to the Delta variant, as well as some of the mutations from Omicron. Will this variant cause another worldwide surge like Delta or Omicron? At this time, experts are not greatly concerned. This, unfortunately, is a true statement. If you haven't had the vaccine or COVID-19 infection yet, it's very likely you will in the next few months. In some communities in North Dakota who do extensive regular community testing, the January 2022 positive rates are as high as 34%. With the prevalence of the highly transmissible Delta and Omicron variants, and the current community positivity testing rates, it's very likely that a person with no immunity to COVID-19 will become exposed and infected. Vaccination, and particularly booster doses, decrease the severity of disease, death, and susceptibility to infection with COVID-19. Let's briefly consider the question, do COVID vaccines really work? How effective are they? This diagram illustrates potential reasons that initial vaccine efficacy may decline, including age of the vaccinee, time from vaccination, or durability of vaccine immunity, and vaccine coverage of variants like Delta and Omicron. This graph shows the results of two large ongoing cohort studies of vaccine efficacy to prevent infection. The HEROES Recover study looks at healthcare workers, vaccinated versus unvaccinated, in several large healthcare systems. These are individuals at increased risk of COVID infection. The NHSN database looks at vaccine efficacy in nursing home residents. The NHSN is the CDC's National Healthcare Safety Network and is the nation's most widely used healthcare-associated infection tracking system. Individuals in the HEROES Recover group are likely healthier than those more frail individuals in the NHSN study. This is data looking at efficacy against infection. As demonstrated, efficacy to prevent infection declined over time in both studies. In the HEROES Recover study, the decline was from 91%, which persisted for about 5 months, to approximately 65% after 6 to 7 months. In the NHSN group, initial efficacy was approximately 75%, declining within 3 months to approximately 55%. Although this decline is disappointing, it is important to note that this means that these vaccinated subjects are still 55 to 65% less likely to get an infection than those unvaccinated. These declines over time underline the importance of booster doses. This graph demonstrates the results of 3 different databases for adults 18 years and older and veterans. All 3 databases show a consistent and persistent vaccine efficacy to prevent hospitalization in these adult populations. This MMWR article from July 2021 summarizes the efficacy of COVID vaccinations after Delta became the most common variant in the United States. Fully vaccinated individuals had a five-fold decline in COVID infections, a greater than 10-fold decline in hospitalizations and deaths versus the unvaccinated. Vaccination offers strong protection against COVID-19 infections, hospitalizations, and death. This graph shows the age-adjusted COVID hospitalizations by vaccine status for individuals 18 years old and older from January to August of 2021. Almost all of the hospitalizations are seen in the unvaccinated group. This study looked at COVID case rates in the unvaccinated and those vaccinated with either the J&J, Pfizer, or Moderna vaccines. Over the 6-month study period, the unvaccinated had a 6.1-fold greater risk of testing positive for COVID-19 and 11.3-fold greater risk of dying from COVID-19. So any COVID vaccine provided significant protection against infection and death. We see these same results regionally. Sanford Health regularly reports COVID data for unvaccinated and vaccinated patients that includes those hospitalized, those admitted to the ICU, and those on ventilators. The report on October 12th demonstrated that 91 to 97% of those hospitalized in the ICU or on a ventilator were unvaccinated. This table shows COVID hospitalizations of children and pregnant women based on their vaccination status from September 1st, 2021 to January 6th, 2022. 95% of pediatric COVID hospitalizations and 93% of pregnancy-associated COVID hospitalizations were in the unvaccinated group. Vaccination is key to prevent severe disease due to COVID-19. This is a 2021 study of the survival of over 700,000 veterans, followed for 26 weeks after a PCR test for COVID-19 in those that were either fully vaccinated or unvaccinated. The survival rate for those fully vaccinated and PCR negative demonstrated the highest survival rates over the 26 weeks of study. The vaccinated individuals who tested positive for COVID-19 had a survival rate similar to those unvaccinated and tested negative. The unvaccinated who tested positive for COVID-19 had a marked poorer survival rate over the study period. This important study reported in the MMWR looked at non-COVID mortality in 11 million vaccinated versus unvaccinated persons. Some people believe that the death rate is higher in individuals who received the COVID vaccination than those unvaccinated. This study demonstrated the opposite, that those who received an mRNA COVID vaccine had a 66 to 69% decrease in death over a 7-month period versus unvaccinated individuals. Those that received the J&J vaccine had a much more modest reduction in mortality. The authors were not able to adjust for underlying health status, so there is potential for healthy vaccinee bias, where healthier people may tend to seek vaccination more than unhealthy people. These graphs show data of a study from Israel reported in the New England Journal of Medicine. This demonstrates marked reduction in reinfection in people over 16 years of age with a history of COVID infection who received at least one dose of vaccine. So natural immunity alone is not as good as natural immunity plus 1 dose of vaccine. It's interesting that there was no advantage in receiving 2 vaccine doses after prior infection. It makes sense to encourage individuals with a history of COVID infection to get 1 dose of the vaccine. Data from the New York State Department of Health and State University of New York evaluated vaccine effectiveness in children by age group during the Omicron wave. In the under 11-year-old group, vaccine efficacy fell to negligible protection against infection and only a 48% protection against hospitalization, though that's still better than 0. This may have been due to the lower dosage of mRNA vaccine in this 5 to 11-year-old age group, since this decrease was not seen in 12-year-olds that received a higher dosage of vaccine. A report from Israel on June 26th stated that the Delta variant is infecting vaccinated individuals and that vaccinated individuals represent as many as 50% of the cases. Now, this is not surprising, since Israel has exceptionally high vaccination rates, and the main goal of COVID vaccines was to decrease severe disease and death, not necessarily prevent infections, though from our previous discussion, it also decreases infection rates 5-fold in those vaccinated. Base rate fallacy explains this observation. To explain base rate fallacy, let's say we have a highly vaccinated population like Israel, where 90% of the population are vaccinated, represented by the 90 individuals in the vaccinated square, and 10% of the population are unvaccinated, represented by the 10 individuals in the unvaccinated square. Let's say all 100 individuals in the population are close contacts to individuals infected with the highly transmissible Delta variant. The attack rate in the unvaccinated group is 50%. Using a realistic 5-fold decrease in the Delta variant infection rate in vaccinated individuals from the MMWR article in July 2021 we previously discussed, the attack rate for the vaccinated group would be about 10% for breakthrough cases. So in this population, we would have 9 people infected who had been vaccinated and 5 infected who were unvaccinated. In other words, in this highly vaccinated population, 9 of 14, or 64% of infected individuals would be vaccinated. This is the base rate fallacy. The higher the vaccination rate of a population, the higher the number of infected individuals will be vaccinated, even if they have a 5-fold decreased infection rate versus the unvaccinated. Let's discuss third dose and boosters briefly. In this study from 2021, neutralizing antibody can be identified in 98% of healthcare workers after vaccination. This immune response is decreased in various immunocompromised groups. 55% of individuals with hematologic malignancies develop detectable neutralizing antibodies, and only 37% of individuals with solid organ transplants after a primary COVID vaccine series. Because of this limited immune response in moderately or severely immune-compromised patients, a third dose is recommended as soon as 28 days after the second dose. This is not a booster dose, but a third dose of a primary series. The FDA approved an emergency use authorization, EUA, and the CDC also approved booster doses for Pfizer, Moderna, and the Johnson & Johnson vaccines. For Moderna vaccine, a single booster dose should be administered at least 5 months after completion of the primary series to all individuals 18 years old and older. For Pfizer vaccine, a single booster dose should be administered at least 5 months after completion of the primary series to all individuals 12 years old and older. A booster dose should be administered at least 2 months after completion of the single-dose primary regimen of the J&J vaccine to individuals 18 years of age and older. The FDA and CDC also approved the use of any of the available COVID-19 vaccines as a heterologous or mix and match booster dose in eligible individuals following completion of a primary vaccination regimen as appropriate for their age, though there is a preference for mRNA vaccines unless contraindicated. This chart compares vaccination rates between the United States, England, France, and Austria. The U.S. lags a bit on completion of a primary COVID vaccination series for those 18 years old and older, and is essentially tied with Austria on primary series vaccination rates for individuals under 18. The U.S. markedly lags behind these other 3 countries on booster doses for those 18 years old and older, and is in the middle of the pack for those under 18. As previously mentioned, booster doses of COVID vaccines dramatically increase neutralizing antibody and protection against symptomatic infections from Omicron. Boosters may provide up to 76% protection against infection and 85 to 90% protection against severe disease. Increasing booster doses in populations will likely blunt outbreaks of Omicron and other variants currently circulating. Let's briefly consider the safety of COVID vaccines. Billions of doses have been administered globally since late 2020. So we have extensive experience worldwide and in the United States to evaluate the safety and efficacy of the COVID vaccines. These are some of the most studied and monitored vaccines in the world's history. The United States has an exceptional multi-layered system to monitor the safety of medications and vaccines. This system includes both pre and post licensure processes and programs, including the safety and efficacy studies of the 3 phases of clinical trials, the Vaccine Adverse Events Reporting System, VAERS, the Clinical Immunization Safety Assessment Project, CISA, the Vaccine Safety Datalink, VSD, Post-Licensure Rapid Immunization Safety Monitoring System, PRISM, and vSafe. Let's briefly review the Vaccine Safety Datalink, VSD program that utilizes rapid cycle assessments for vaccines like those for COVID-19. The Vaccine Safety Datalink VSD program is an active safety monitoring tool. It was developed by CDC approximately 30 years ago. It covers 12 million people linked through managed care organizations, MCOs. Data includes vaccinations, hospital and outpatient information, and laboratory data. VSD utilizes rapid cycle analysis, RCA, which was developed by the VSD program to monitor pre-specified vaccine-related safety outcomes in near real time. Rapid cycle analysis commonly utilizes either self-controlled or current historical study designs with appropriate control groups, data quality, and adjustment for confounding factors. Every week, RCA compares rates of pre-specified outcomes in pre-specified time windows. 90% of initial adverse event signals turn out to be spurious by rapid cycle analysis. So initial adverse event signals from initial surveillance processes are not very specific, These signals are false positive 90% of the time. This map shows the 9 participating healthcare organizations that provide data to the Vaccine Safety Datalink program. This article in the New England Journal of Medicine from August 2021 did a matched control study in Israel for the 25 conditions listed. This slide summarizes the results of that study. The risk from vaccine is in blue and from COVID infection in orange. Vaccination was most strongly associated with an elevated risk of myocarditis, lymphadenopathy, appendicitis, and herpes zoster. COVID infection was associated with a substantially increased risk of myocarditis, pericarditis, arrhythmia, deep vein thrombosis, pulmonary embolism, myocardial infarction, intracranial hemorrhage, and thrombocytopenia. So the vaccine was not associated with an elevated risk of most of the adverse events examined. The vaccine was associated with an excess risk of myocarditis, but the risk of myocarditis from COVID infection was much greater, along with marked increased additional serious health risks. Another concern often expressed is regarding the newness of the mRNA technology. This slide briefly summarizes the history of the development of mRNA vaccines. These vaccines evolved from research regarding the use of lipid nanoparticles in the 1980s, the development of techniques to synthesize mRNA for injection into cells in the 2000s, and the 2012 study of MERS and the potential use of spike proteins in vaccines. Today's success with mRNA vaccines comes from the decades of research finally resulting in the COVID vaccines we now have today. These are 2 important statements to consider regarding the safety of COVID vaccines. In the history of all licensed vaccines in the United States, no serious side effects have ever been found after 6 weeks. All of the currently available COVID vaccines have now been studied for 6 to 12 months. Even with that being said, the vaccine safety monitoring systems we briefly discussed will continue to monitor these COVID vaccines along with all other vaccines for safety. There is no endpoint for vaccine safety monitoring. Let's spend a few minutes discussing the rare but serious side effects reported from COVID vaccinations. All COVID vaccines have a 5 per million risk of anaphylaxis. That's why observation for 15 minutes post-vaccination is recommended not only for COVID vaccines, but for others that also have been associated with rare anaphylaxis events. The Janssen or Johnson & Johnson vaccine has been associated with a 3 per million risk of thrombosis and thrombocytopenia syndrome events for all vaccinees, with an 8 per million risk for young females. Guillain-Barré has been associated with 7 per million risk for all vaccinees, with a 15 per million risk for older males. For the mRNA vaccines, the risk of myocarditis for all vaccinees is 3.5 per million, with a risk for young males of 25 to 50 per million. The CDC and ACIP now prefer the use of mRNA over the Janssen or J&J vaccine for the following reasons. When compared to mRNA COVID-19 vaccines, the J&J vaccine is less effective in preventing COVID-19 hospitalizations, ICU admissions, and deaths. Also, the J&J vaccine causes more severe health impacts or adverse events from TTS, thrombosis with thrombocytopenia syndrome, and GBS, Guillain-Barré syndrome, compared to the adverse event of myocarditis after mRNA COVID-19 vaccines. So in a setting where mRNA and Janssen COVID-19 vaccines are both available, mRNA COVID-19 vaccines are preferable for all age and gender groups. This slide summarizes the best and worst case scenario risks for myocarditis in healthy young males. The vaccine risk ranges from 1 in 8,000 to 1 in 20,000. The COVID infection risk for myocarditis in these young healthy males ranges from 1 in 43 to 1 in 1,000. So the risk of myocarditis is much greater with COVID infection than with the vaccine. Vaccination will help reduce the risk of myocarditis in young, healthy males. Another safety concern is the vaccine impact on female fertility. Does the COVID vaccine cause female infertility? This is false. The COVID-19 vaccine does not cause female infertility. So what can be done at the medical encounter to encourage vaccinations like those for COVID-19? Note the results of this study that patients still trust their own doctor or clinical provider for information about COVID vaccines above the CDC, the FDA, local or state public health officials, the president, or Dr. Fauci. This relationship of patient and family to their healthcare provider is an extremely important channel to provide accurate information regarding vaccines like those for COVID. Let's talk about a few key concepts regarding the vaccine conversation. This study in the journal Vaccines from December 2020 looked at influences on attitudes regarding COVID vaccinations in the United States, including intent to be vaccinated, beliefs about whether COVID is actually a problem, whether they believe COVID vaccination is important, and if they were worried about side effects. Approximately 3% strongly disagreed that COVID vaccine is important, and about 8% strongly intended not to be vaccinated. These individuals I would classify as strongly resistant to COVID vaccinations. The approximately 40 to 45% of individuals who somewhat agree, neither agree nor disagree, or somewhat disagree with an intent to be vaccinated or think the COVID vaccine is important are those clinicians should consider spending more time with to answer their concerns, including questions about vaccine safety. The way we communicate a recommendation to patients is important. There are essentially two major ways to make vaccine recommendations: participatory or presumptive recommendations. An example of a participatory recommendation is listed here. Would you like an influenza vaccine today? This implies you can either get it or not and leaves the patient with the impression of uncertainty. A presumptive recommendation would be the following. I strongly recommend we give you the COVID vaccine today to protect you against severe disease and death. Do you have any questions about that? This statement implies that the vaccine is essential for health and wellness, like diuretics for heart failure or antibiotics for an infection. Presumptive recommendations are much more effective than participatory ones for increasing immunization rates. Additional tools to increase vaccination rates in the clinical setting include using relatable stories, EASE, and motivational interviewing. Stories are powerful tools to provide patients and families with information. As clinicians, we should be ready to tell relatable stories to illustrate the importance of vaccinations like COVID. Here's an example of a story regarding the importance of COVID vaccines. Mr. Rob Terstig was a 46-year-old oil field worker living in Minot with his wife and 3 children. His wife is a nurse at Trinity and was vaccinated early during the pandemic. Rob felt he was healthy and didn't need the vaccine. Unfortunately, he contracted COVID-19 in May and became critically ill. He was transferred by life flight to Minneapolis for a higher level of care since he needed ECMO. He quickly declined, and he suspected he may not survive. He told his wife he regretted not getting the vaccine and made her promise to vaccinate all their children when they were eligible. He died on June 3rd, after weeks of treatment in the ICU. His wife and family were not able to be with him in the hospital due to restrictions the last days of his life. The point here is to encourage providers to tell relatable stories to their patients and families. Let's now briefly discuss a few concepts of the EASC and motivational interviewing approaches. The writing reflex is also often described as the fix-it mode. Diagnose it and control it. The writing reflex stems from a belief that people don't know, therefore we need to give them information. They don't understand, so we need to give them insights. They don't care, so we need to scare them to make them concerned, and or they don't know how to do something, so we need to give them skills. The least desirable situation is when a provider is arguing for a change while the patient or family is arguing against it. This situation is often the result when the clinician uses the writing reflex or fix-it mode and often leads to patients becoming defensive. Simply reducing discord increases the odds of a good clinical outcome. Patients want and need to be listened to, be understood, and also need to be the source of the solution. We need to realize that they will be the ones who finally decide whether to get a vaccine or not. Use of the writing reflex leads to discord, which leads to the patient shutting down or becoming defensive. This statement comes from Rolnick et al. In a book titled Motivational Interviewing in Healthcare, Helping Patients Change Behavior. There is something in human nature that resists being coerced and told what to do. Ironically, it is acknowledging the other's right and freedom not to change that sometimes makes change possible. Brehm in 1966 described the psychological reactance theory, which says that problem behavior becomes more attractive if a person perceives that his or her personal freedom is being infringed upon or challenged. Have you ever personally done the opposite of what someone told you to do, even though what they suggested is quite reasonable? If that happens in us, it can also happen in our patients. People would rather demonstrate their autonomy than comply. Sometimes healthcare professionals trigger this reaction because of the approach we have taken. If we use language like you need to, you got to, you must, etc., we may trigger this reactance response in our patients. These are common reactions when providers use the writing reflex fix-it approach and stimulate the reactance response. I assume many or most of us have seen these reactions occasionally in our patients and families, including anger, arguing, defensiveness, justification, disengagement, not coming back for appointments, etc. Shifting from the writing reflex fix-it approach to a more empathetic, listening, understanding, bringing the patient into owning the solution type of approach may result in a change of behavior and avoid the reactance response. The EASE approach has 4 steps. Elicit main concerns, acknowledge the main concerns, share your commitment, educate and endorse with permission. The first step is elicit main concerns. Ask the patient for their agenda or what they want to accomplish during the visit. This is eliciting their main concerns. Ask the patient for permission to add your agenda items for the visit, like laboratory tests, vaccinations, etc. Consider using scaling questions if appropriate. For COVID vaccinations, it may be, on a scale of 0 to 10, how important would you say it is for you to receive a COVID-19 vaccine today? This slide provides a few suggestions on how to use scaling questions. Ask why they didn't choose a lower number on the scale. For example, you said your interest level is at 2. Why didn't you say 0? Their response may provide reasons for them to consider vaccination. Wait for their response and restate their answer, which may further encourage them to consider vaccination. Follow up with, why else were you higher than a 0? Another follow-up question could be, your answer was not 7 or 8. What would you need to see to get to that level? As mentioned before, resist the writing reflex fix-it approach. Avoid telling them what to do. Use empowering language. Be a guide, not a lecturer. Say something positive about your patient. For example, I'm glad you were really thinking about the pros and cons of getting vaccinated. The second step is acknowledging the main concern without validating misinformation. This could include an acknowledgement of fear, anxiety, beliefs in inaccurate information, etc. Actively listen to the patient's concerns. Seek to understand their values, needs, and where their ambivalence lies regarding things like COVID-19 vaccine. Reflect and restate what you are hearing, which often helps individuals reassess their perspective when they hear it stated from another person. Restating also helps clarify and confirm what you thought the person said. Allow the patient time to respond to your reflection and restatement of the concern. You may want to ask the patient to further clarify their concern. Could you tell me more about that? This step, if done well, expresses empathy. The third step is share your commitment. While honoring patient autonomy, share your commitment to taking good care of your patients. You may want to say something like, we share the same goal of figuring out the best course for your health. Share your recommendations with permission. You could say, you have trusted me in the past for your health advice. Would it be all right with you if I make a recommendation? If the patient gives permission regarding COVID vaccinations, you could say, based on the current information, I do recommend that all of my patients get vaccinated against COVID-19. Check in with the patient after you make recommendations. You could say, what do you think about my recommendation? The fourth step of EASE is educate and endorse. As with recommendations, ask permission before sharing information honoring patient autonomy. You could say, would it be all right if I share some information that others found helpful when making a decision about the COVID-19 vaccination? Provide clear and concise information on the level of a patient's understanding regarding things like COVID-19 vaccine concerns. Ask the patient to reflect and respond to the information you shared. What do you think about the information I just shared? Keep the education and endorsement step brief. You should not try to educate on more than 2 to 3 points during a visit. In summary, North Dakota has a lower COVID vaccination rate than the national rate. mRNA vaccines are non-replicating and do not change the DNA of vaccine recipients. COVID vaccination decreases COVID infection, hospitalization, and death rates. The base rate fallacy can cause confusion with high vaccination rates. COVID vaccine benefits far outweigh the risks from COVID disease. Personal clinicians are trusted sources of health information. Clinicians should use best and promising practices to encourage vaccinations during clinic visits.